Physiological conditions. Hypertension is abnormally high blood pressure. There are two types of hypertension. Primary, essential, elevations in blood pressure that have no identified cause, related to factors such as age, African American ancestry, weight, sodium intake, tobacco, and lack of exercise. Secondary, much less common, stems from other diseases, arteriosclerosis, the loss of elasticity or hardening of the arteries, kidney disorders, disorders of the endocrine system. Hypertension is the single most important risk factor in CVD, but most are unaware of their vulnerability. Dangerously elevated blood pressure levels can occur with no symptoms. Serum cholesterol level is the level of cholesterol circulating through bloodstream. It is a waxy fat-like substance which is a component of cell membranes, insulation for neurons, and an ingredient in the production of certain hormones. The liver manufactures cholesterol, but it also comes from diet. The Framingham study found men with low levels of serum cholesterol seldom developed CHD, but those with high levels had an elevated risk. This relation did not appear in women in the study, possibly because so few had developed heart disease. Women's high HDL, good cholesterol levels, may be a partial explanation for the gender gap in heart disease. HDL levels are more predictive of heart disease for women. Hormone replacement therapy increases HDL. Note, remember you want LDL, bad cholesterol, to be low, and HDL, good cholesterol, to be high. Lowering serum cholesterol may not be important for people past 70. Data from Framingham in 1993 showed a significant positive relation between total cholesterol levels and death from heart disease only up to age 60. From 60 to 70 there was no significant relation, and after age 80 total serum cholesterol levels may actually have a protective effect against death from CVD. Behavioral factors. Smoking. More cigarette smokers die from CVD than from all forms of cancer combined. When the Framingham study began in 1948, little evidence suggested that smoking would be a risk in CVD. No link was demonstrated in women, perhaps because so few women in Framingham study smoked and fewer developed CVD. Later evidence showed a link between both fatal and non-fatal heart attacks and smoking among women. Obesity. People with apple shapes carry weight around their heart and are at greater risk than pear shapes, those that carry weight around their hips. Men are more likely to be apples. Apples tend to have lower HDL levels than pears. Diet contributes more to chances of developing heart disease than being overweight. A study of 12,000 males of Japanese origin was conducted in 2 different Japanese cities as well as Honolulu and San Francisco. The men had similar biographic background, but men living in Japan consumed a low-fat diet of fish and rice and had the lowest rate of cardiovascular problems. Men in San Francisco had the highest rates. Diets were 40% higher in fat. Men in Honolulu were midway between these two in both dietary fat and cardiovascular problems. In 2012, a study of men found a link between lycopene and lower stroke. Diets high in saturated fats positively related to heart disease. Diets low in saturated fat protect against heart disease. Stampfer in 1993 conducted an 8-year follow-up of more than 87,000 female nurses between the ages of 34 and 59 free of CVD. Those who consumed more vitamin E were only 2/3 as likely to develop CVD as those that consumed less vitamin E. Beta-carotene, selenium, and riboflavin are also antioxidants. Illness perceptions and outcomes. When patients hold negative perceptions about their illness, These beliefs are associated with a greater likelihood of future disability and slower recovery. Illness perceptions not only fail to relate closely to objective measures of disease severity, but are also better predictors of outcome. Heart attack patients who believed their illness had been caused by their lifestyle were found to be more adherent to lifestyle change advice, whereas those who identify stress or genes as key causes were less inclined to make changes. Depression. Dickens in 2008 measured illness perceptions in first-time heart attack patients and examined depression the following year. Patients who developed depression following a heart attack were more likely to believe at baseline that his heart condition would last a long time and was unlikely to be cured. Given the relation between illness perceptions and outcomes, the focus should be on developing interventions to modify dysfunctional illness beliefs to improve outcomes. Broadbent in 2009 showed that changing heart attack patients' beliefs about their heart attacks improved recovery and return to work. Psychosocial factors. Optimism. Coronary bypass patients who were optimists used more problem-focused coping and less denial. They had faster recovery rates and faster rates of returning to life activities after discharge. Optimism also predicted fewer rehospitalizations following a CABG surgery. That's a coronary artery bypass graft. Social support plays a role in development and progression. Most studies examining social ties and mortality in those with CVD focus on those with myocardial infarctions or chronic diseases like heart failure. None have examined mortality as far as 15 years after diagnosis of a major cardiac event. Studies of effects of marital status, whether a person is married or not, on mortality from CVD are more common than studies on marital satisfaction. Most studies find unmarried persons, especially never married, have higher relative risk of death from chronic or acute CVD starting in middle age. Marital status and cardiovascular mortality studies are often conducted with epidemiological data sets, which have advantage of large samples, but disadvantage of being neither prospective nor also considering marital quality. King and Reese in 2012 addressed these limitations and found that married subjects were 2.5 times more likely to be alive after CABG than those who were not married. Those in high satisfaction marriages were 3.2 times more likely to be alive 15 years after CABG compared to those with low marital satisfaction. Education level and income. Low levels of education and/or income link with cardiovascular risk. Those with less education are more likely to be overweight, have high blood pressure, and less access to care. In the InterHeart study, low socioeconomic status placed people at risk for heart attack. Note, the InterHeart was a huge case control study of 15,000 cases who had heart attacks and over 13,000 controls from 52 countries. Stress, anxiety, and depression. People in InterHeart who had heart attacks had more work and financial stress and more life events than controls. Depression predicts the development and progression of CVD. Research with adolescents showed that they had artery damage. Cynical hostility and anger. Much of the research on the cynical hostility and anger grew out of work on type A personality. A type A personality is hostile, competitive, concerned with acquisition of objects, exaggerated sense of time urgency. A type B personality is not just the absence of type A characteristics. Kaplan in 1992 suggests type B also includes forgiveness, sense of humor, healthy humility, high self-esteem, sense of autonomy and uniqueness, a balance between achievement and aspirations, demands and realizations, gifts and limitations. Hostility and suspiciousness were the components of type A that were best predictors of CVD. Note, Not all type A's measure high on these two traits. The most frequently used scale for hostility is the Cook Medley. It consists of 50 items from the MMPI. Hostility increases risk for CHD, and it can also lessen the benefits of receiving social support. Hostile individuals report more negative life events and have difficulty getting social support, or may fail to make effective use of it. A Swedish study followed 6,861 men and women for nearly 10 years. Those with low social participation, measured by interview, had the highest risk of CHD and were more than twice as likely to have another heart attack than those with high social participation. Men are more hostile, and male children have higher scores than female children. African American men score higher than African American women or white men. Hostility is a better predictor of coronary artery blockage, heart disease, and all-cause mortality than type A. Brissett and Cohen in 2002 found that those high in cynical hostility have more conflict with others, more negative affect, and more sleep disturbances. Those who are both hostile and defensive do not report socially undesirable aspects of themselves, show greatest association between cardiovascular response and CHD. Anger, a specific component of hostility. Barefoot in 1989 suggested that hostility may be too general, and cynicism and expressed anger may be better predictors of heart disease and death than global concept of hostility. Siegman in 1987 note that experience of anger probably does not threaten cardiovascular function, but expression does. They found that expression of anger hostility in angiographic patients was positively related to the severity of the coronary artery disease. What is the mechanism? Provoked anger in lab settings increases measures of cardiovascular reactivity, specifically systolic and diastolic blood pressure. Women may not experience comparable reactivity when provoked. Suppressed anger or holding anger in. There was a significant correlation between anger in scores and CAD for a group of male patients who received cardiac catheterization. However, anger in may be a result of heart disease rather than a contributor to it. Once diagnosed, we may be warned by a doctor not to get angry. Once diagnosed with heart disease, anger, whether expressed or suppressed, makes the condition worse.